Welcome everyone. Welcome to the She Matters Wellness Webinar Series, March 2026. We were very happy to celebrate Women's Day on 8th of March. In continuations of that celebration, we are hosting a series of webinar talks with all our doctors from Wellness by Heartfulness and at Kanha Wellness Center. I'm Dr. Nandini, a naturopathy physician from Wellness by Heartfulness, today moderator. Today we are discussing a very important topic, women's health screening across the life course. Most discussions around women's health focus mainly on reproductive health, but modern research shows that hormonal transitions influence metabolic health, cardiovascular disease, and long-term well-being. To help us understand this better, we have Dr. Vidyavathi with us today's session. She is a consultant pathologist with an MBBS and MD in pathology, and she is also a gold medalist. She is a diplomat of the American Board of Lifestyle Medicine and has intensive experience in diagnostic as well as preventive medicine. She has trained and worked at several reputed institutions such as Kurnool Medical College, Christian Medical College, Apollo Cancer Specialty Hospitals, ESI Medical College, and SRL Diagnostics. Currently, she is working as a consultant pathologist at Kanha Medical and Research Center, Kanha Shantivanam, where she focuses on preventive health, metabolic screening, and women's health. She is also a heartfulness practitioner and trainer, integrating scientific medicine with lifestyle and mindfulness approaches for holistic health. Thank you so much, Doctor, for joining us today's session.
Thank you, Dr. Nandini.
Doctor, let's begin with the bigger picture. Why do we need a life stage approach for screening instead of a single strategy for all women?
Yes, Nandini. Women's health is significantly impacted by hormonal changes throughout their life. For example, if you take a 12-year-old child or a 30-year-old woman and 55-year-old woman, their body metabolism, body composition, hormonal physiology, everything is different. A woman undergoes through various phases of life like puberty, reproductive years, perimenopause, menopause, and post-menopause. These transitions affect metabolism, cardiovascular health, bone health, and body composition, leading to various disease risks. This means that screening strategies must adapt to these biological changes, as women do not suddenly develop diseases. Rather, disease risk evolves with hormonal transitions.
Okay. Before we discuss screening, could you explain the current epidemiology of women's health in India?
Yes, knowing Indian epidemiology is more important. It shows the women's health burden in India. In India, women's health issues focus on three main disease groups: cancers, especially breast and cervical cancers, cardiometabolic diseases like diabetes, hypertension, and bone health disorders like osteoporosis. Breast cancer accounts for 26 to 27% of female cancers, while cervical cancer causes highest mortality, particularly in the rural areas. Under national NCD programs, over 10 crore women over 30 years of age are already screened for cancers. Cardiometabolic diseases such as diabetes and hypertension are rising, with the cardiovascular disease being the leading cause of death among post-menopausal women. Discussions on women's health should encompass metabolic and cardiovascular risk prevention beyond just reproductive health. And also, I would like to emphasize why Indian women need a different screening strategy. We need to mention about Indian phenotype. There is higher insulin resistance in Indian women in spite of having lower BMI. BMI means body mass index, which is a calculated thing. can be calculated by weight by height square, weight in kilos by height in meter square. Compared to Western population, the BMI for classifying obese women is more than 25 in a Western woman, whereas in Indian women it is 23. So Asian cutoff is lesser. Even they are having BMI, there is hidden insulin resistance in Indian women. Also, the central obesity, that means the obesity or fat accumulation around internal viscera, which is a direct risk factor for cardiogenic risk. So, this central obesity, in spite of having normal weight, is more common in Indian women. And these two, insulin resistance and central obesity, contributes to earlier diabetic onset, that too 5 to 10 years earlier than the Western population. Also, the prevalence of lipoprotein A, which is a very bad cholesterol, that is LDL cholesterol having a protein attached to its membrane called apolipoprotein A. So, this is genetically transmitted protein. This incidence of lipoprotein A in Indian population is more common than the Western people. Also, the prevalence of vitamin D deficiency is common. Almost 70 to 90% of women in India are deficient in vitamin D. Also, the increase in breast cancers in urban areas and cervical cancer deaths in rural areas need to be known. Why we need the strategy for screening in Indian women at different phases, and the screening should start from the puberty onwards. So I need to mention here, women do not transition from health to disease abruptly. They transition hormonally and disease follows biology.
So the key idea is that disease risk follows biological transitions, not just chronological age. Let's start with the earliest transition, puberty.
Yes. Puberty occurs between the ages of 8 to 13 years. We need to know here one thing, that HPO axis, hypothalamo pituitary ovarian axis. So the hypothalamus is a part of the brain. The hypothalamus measures like an almond size just above the pituitary gland. This is called master orchestrator of brain, because all the metabolism, thermal regulation, hunger regulation, thirst regulation, and this even reproductive thing, everything is it's a trigger is the hypothalamus. So by activation of this HPO axis, the puberty begins. The hypothalamus secretes GnRH, called gonadotropin releasing hormone, which acts on the anterior pituitary lobe to secrete gonadotropins called FSH and LH. They act on the ovary. So under the influence of FSH, the follicles they secrete estrogen, and LH stimulates the ovary to secrete progesterone. So this is a normal HPO axis. Whenever this HPO regulation or is dysregulated, then we see the conditions like PCOS, all these things, and infertility issues in a reproductive age. So this HPO axis should be intact to maintain the normal menstrual cycle, which is the normal health for a pubertal girl. And coming to Indian epidemiology, I already discussed you that vitamin D deficiency is very common in more than 70% of people. In this age, the children are more deficient in iron. So nutritional anemias are common, and childhood obesity is in urban population is also very prevalent. Out of 114 to 20% are obese, and this obesity increases insulin resistance. So the risk of PCOS is beginning in the adolescence age.
That's fascinating, doctor, because we often think of puberty only as a reproductive milestone, but you are describing it as a metabolic programming stage. If that's
Yes.
the case, what screening or monitoring should clinicians consider during adolescence?
Yes. So under the influence of estrogen, the estrogen is a metabolic hormone, as we all know. So estrogen helps in insulin sensitivity and female fat distribution. And estrogen also helps in growth hormone surge. And peak bone mass also increases during the pubertal stage. So the screening should aim at following. Like the goal during puberty is early risk identification rather than disease diagnosis. So we should screen a woman from the pubertal age. So the goal is to concentrate on the risk identification rather than disease diagnosis. The key screening measures are BMI monitoring, and BMI, as I told you, that body mass index more than 23 can be calculated, can be an obese, to classify her as an obese woman. And waist circumference. Waist circumference more than 80 centimeters in a woman is called overweight. More than 88 centimeters is called obese. So waist circumference is more contributory to cardiovascular risk than the BMI. And blood pressure measurement. And if there is family history of obesity, we need to screen for a onset of diabetes like HbA1c and fasting insulin. For menstrual health, we need to ask history whether her menstrual cycles are regular or irregular. Also, whether there are anovulatory cycles. Anovulatory cycles, I'll tell you in the next slide what is anovulatory. So they have excess menstrual flow. They should be screened for iron deficiency anemia. Also, the storage iron called ferritin. And vitamin D also to be screened in this age group. If menstrual cycles remain irregular more than 2 years after menarche, menarche means first attainment of menstruation is called menarche. So if irregular menstrual cycles are there, even after 2 years of menarche, we need to evaluate for PCOS. The PCOS girls will have the hyperandrogens in their circulation, so they develop hirsutism, that facial hair, and they have central obesity, insulin resistance, and under ultrasound we may see cystic ovaries, and they may have future risk of insulin resistance and development of type 2 diabetes. Also, they are prone for female infertility.
So the emphasis is here is identifying risk factors early rather than diagnosing disease. Once this stage passes, women enter the reproductive years, which are often considered hormonally protective. Could you explain why, doctor?
Yes. And one more thing I forgot to mention here, this age, pubertal age, is an ideal age for HPV vaccination to prevent future cervical cancer, which is, I told you, the major global burden is contributed by Indian population. So HPV vaccination should be done before 14 years of age, 9 to 14 years of age. And now going to reproductive age. So here I will explain you this diagram. This is normal 30-day menstrual cycle of a girl. And these are the hormones. I have already mentioned HPO axis, that FSH, LH, estrogen, progesterone. So normal healthy woman will have everything balanced. Like I tell you, ovulation occurs at the 14th day of cycle. If a 30-day cycle is there, ovulation means release of ovum from follicles happens at 14th day, and 3 days before and 2 days after is a fertile window where if ovum gets fertilized into an embryo, it can be implanted in the uterus. If it is that doesn't get implanted, it becomes degenerated to give corpus luteum, which secretes progesterone. So the follicular phase, first pre-ovulatory phase is called follicular phase. First 5 days are the menstrual cycle. This follicular phase is under the influence of estrogen, whereas luteal phase, it is under the influence of progesterone. So in a normal healthy woman, the LH surge occurs at the 14th day. So why we should understand this is, once we know this, what to monitor and what to observe, all these things we'll understand. We know once physiology, pathology we can easily understand. The main focus in reproductive age is we need to screen for cervical cancer as early as 21 years of age. Also, sexually transmitted infections should be screened. And this is the age for pregnancy, so she can be given pre-conception counseling regarding her anticipated pregnancy. And in this age also, we need to screen metabolically for HbA1c, insulin, if risk factors are there, family history is there, or she is obese and having high fasting insulin, we need to screen for diabetes. Also, this age, we need to support mental health and lifestyle screening, lifestyle advice, all these things we need to give her. So in the reproductive years, we just say it is hormonally balanced phase because estrogen, progesterone, FSH, LH, everything is under balance. So it is called hormonal rhythm phase. But still we should remember that it is a silent phase because estrogen is a metabolic protector in reproductive years. So it is masking some insulin resistance and future risks. So we should have this in mind. It usually lasts from 15 to 40 years. Here, cyclical hormonal changes occur and they're balanced. So, because under the influence of insulin, the women have healthy fat distribution, good cholesterol, HDL cholesterol, because this estrogen influences thyroid axis and it releases nitric oxide from vascular endothelium. They have good vascular compliance and improved insulin sensitivity. So reproductive years are often considered hormonally protective phases. However, several metabolic risks can still develop silently, like PCOS, which is very highly prevalent in Indian women, and lean insulin resistance. Though the weight is normal, but she may have insulin resistance. And subclinical hypothyroidism also we need to detect. And in this phase, once pregnancy is also a physiological state in the reproductive stage, during pregnancy, the cardiac output increases by 40 to 50%, and also physiological insulin resistance to support the fetal growth. And importantly, pregnancy complications such as gestational diabetes or hypertensive disorders are now recognized as early markers of future cardiovascular and metabolic diseases. That means if a patient in pregnant is having preeclampsia or eclampsia, hypertension, or she is having some gestational diabetes, she is prone to develop type 2 diabetes and essential hypertension in her next phases. So pregnancy is often described as a natural cardiometabolic stress test for women.
That idea that pregnancy can function as a natural cardiometabolic stress test is particularly interesting. During these years, what routine screening strategies should clinicians prioritize?
Yes. Screening during the reproductive years, I also mentioned previously in the pubertal age. Same thing follows, like we need to mention every visit BP and the HbA1c, fasting insulin, lipid profile, and some risky cholesterols like ApoB and lipoprotein A. Lipoprotein A we measure only once in lifetime because once it is positive, like they have increased tendency to have premature heart attacks, and if there is any family history of premature death due to cardiac arrest, we need to screen their daughters for lipoprotein A. ApoB is atherogenic LDL cholesterol. If it is more than 90, it is increasing risk, so we need to take care. And HSCRP is an inflammatory marker. If they are having obesity and other inflammatory things, we need to screen for HSCRP. And TSH, as I mentioned you, there are subclinical hypothyroid states. And this is the age we screen for cervical cancers. And we can continue HPV vaccine at this age up to 26 years. So the same lipid profiles, all these things will continue. And other inflammatory markers like risk factors we can include in this age group.
So, screening during the reproductive years serves two purposes: identifying metabolic risk and detecting early cancers such as cervical cancer. As a women approach their 40s, hormonal stability begins to change. Could you explain what happens during perimenopause?
Yes, I'll share this slide. So now we have seen the reproductive phase where we screen like high inflammatory markers and these things. As they go to 40 and 50, the hormonal rhythm will get disturbed. So there is unstable estrogen spikes happen in this age. It is from 40 to 50 years of age, and there is erratic ovulation. And perimenopause typically is marked by hormonal fluctuations and irregular ovulation, rising estrogen variability, and increased FSH levels. So whenever we have low estrogen, FSH and LH will be more. That feedback I have mentioned in the first slide. So these high FSH levels, they all result in severe metabolic effects, including increased visceral fat and higher insulin resistance, increased systemic inflammation, sleep disturbances. Here in this graph, you can see the gradual decline in the estrogen levels and mood irritability, and they have mood swings and weight gain. Visceral fat accumulation leads to weight gain, insomnia, nausea. All these things they start at the perimenopause. As estrogen declines, all the protective effects will be declining. And India, diabetes prevalence in women over the 40s is about 18 to 22%, with cardiovascular risk rising sharply after 45. So consequently, screening is crucial during this phase. This perimenopausal phase is characterized by metabolic vulnerability due to hormonal unpredictability. So the screening should be very essential at this stage. We should not neglect. Unlike in reproductive age, perimenopause is a phase for frequent screening and treatment and change in lifestyle.
So, this period essentially becomes the metabolic turning point in women's health, right?
Yes.
What screening tests become especially important during this stage?
Yes. The recommended screening, I told you, no, that visceral fat. So same thing. The screening also should address the pathophysiology. So recommended screening includes BMI, waist circumference, blood pressure, and HbA1c every 1 to 2 years, fasting insulin, lipid profile every 1 to 2 years, ApoB, lipoprotein A if not done previously, HSCRP for inflammatory risk cancer screening, and mammography should start at the age of 40. So far we discussed cervical screening, but mammography to screen for breast cancer. If there is a family history of breast cancer, we should start early by 35. We should start early. And colorectal cancer screening from the age of 45, we should start. And bone health assessment also can be advised if they are having less bone mass and underweight and any family history of fractures. We can do DEXA scan also.
It sounds like after menopause, the focuses of health care shifts from reproductive concerns to cardiovascular protection and bone health. If you
Yes.
had to summarize women's health screening in one message, what would it be, doctor?
Yes. So perimenopause is followed by menopause. So menopause is complete decline in the estrogen. So we discussed what are the positive effects of estrogen. So when there is estrogen decline, the negative effects occur. So high FSH and LH, reduced serotonin. So mood will be reduced, like a lesser loss of result. There's suffering with depression. All these things will happen in menopause, and this vascular compliance will be compromised. So there is increased sympathetic tone and a tendency for hypertension and cardiovascular atherogenesis, like more incidence of cardiovascular diseases. So there is increased ApoB and LDL cholesterol, bone loss can happen, reduced muscle mass, and visceral obesity may increase. So in spite of doing so many things, weight loss will be very difficult at this age. And the menopause also, we need to screen all these tests as I described in the perimenopausal phase, but the frequency should be quite frequent, like HbA1c every 1 year, and lipid profile along with ApoB measurement repeated every 1 or 2 years. And for cardiovascular risk scoring should be performed if they have family history or a previous history of coronary artery disease. We need to score annually. We should score for cardiovascular risk, and BMD using DEXA scanning should be performed. Breast cancer screening with mammography should continue regularly, particularly between ages of 50 and 60, where incidence peaks. Blood pressure measurement should be done at every visit because hypertension becomes quite common. Given the high prevalence of deficiency of vitamin D, it should be also screened. And menopause followed by post-menopause. So post-menopause, when the woman attains complete menopause means absence of menstrual cycles for a period of 1 year is called menopause. So post-menopause state is after 55 years, where several metabolic changes begin to appear. There is increase in atherogenic lipoproteins like ApoB and LDL cholesterol. So all these cardiovascular, here also I am showing this graph, no, like atherosclerotic stages, and bone mass is completely declining. Sarcopenic obesity we call, that is muscle mass is reducing, and they are prone for more fractures, and osteoporosis will be developing in them. After menopause, cardiovascular disease surpasses breast cancer as mortality cause. So here in post-menopause, we have to see for the financial for the independence and stability of the woman rather than hormonal health and all these things. So it is characterized by low estradiol, high FSH, increased inflammatory cytokines. So after 55, screening must shift from hormonal transition to cardiovascular protection, functional independence, bone preservation. So same tests will continue, mammogram, and here the patients may have the depression and cognitive decline, so we need to screen for cognitive thing also. And annual fall risk assessment should be done. Some patients may have urinary incontinence, that should be screened here in postmenopausal women, along with the previous tests which were done in the menopausal stage. And I need to mention regarding the cancer screening, In this table shows all the screening at various stages as we described before. So cervical cancer screening should begin by 21 years or before, after the sexual exposure, and it should continue up to the 65 years. Mammogram ideally should be started by 40 and continue till 75. Colorectal screening. So these are the three preventable cancers. When we screen early, we can easily prevent those cancers. Or even if they are there, early diagnosis also cures completely. So most of the breast cancers, they come very late because they never undergo mammogram in their 40s. And even pap smear is highly preventable cancer. Patient never does pap smear, and if it is diagnosed early, we can completely cure the cancer. But only they appear at the stage 3 or 4 because of unawareness that there is preventive strategies are available. And colorectal screening should continue up to till 75, and DEXA and cardiovascular disease risk scoring should be continued. So women's health should be viewed as a lifelong continuum. So for your question, Nandini, I'm telling. So to concise into one slide, women's health should be viewed as a lifelong continuum. During puberty, we focus on growth and metabolic programming. During reproductive years, we detect early metabolic risk and reproductive health issues. During perimenopause, we identify accelerating cardiometabolic risk. And after menopause, we focus on protecting the heart, bones, and functional independence. The key shift in modern women's healthcare is moving from late disease detection to early risk prediction. This is my final slide. So we are not treating disease late, we are missing risk early. So the three crucial phases are perimenopause, menopause, and post-menopause. And after gaining knowledge, we can be sure that even in puberty and reproductive years also, we can monitor the women's health to prevent future risk. From puberty to post-menopause, and screening strategies must evolve with those biological transitions. Estrogen usually functions as a metabolic shield in women. During the reproductive years, it protects the heart and metabolism and bones. As women approach perimenopause, menopause, and postmenopause, that shield begins to weaken, and after menopause, it is largely lost. That's why screening and prevention become increasingly important with age. So my slogan is screen early, stratify risk, intensify screening after 40, protect heart, bone, and function after 55. Thank you.
That was an incredibly insightful discussion on how women's health risk evolve across life and how early screening can change outcomes. Thank you so much, Dr. Vidyavathi, for sharing your expertise with us.
Thank
As
you,
part of
Nandini.
this
Thank you.
webinar series, we have more interesting sessions coming up with different doctors and important health topics. Our upcoming webinar will be with Dr. Samira, who will be speaking on Ayurvedic secrets for women's health. So please stay connected with us and join our upcoming webinars. Thank you.